Oh, I'm recording this, by the way.
Okay.
Welcome in, everyone. Welcome to Tuesdays and Thursdays with Care Patrol. We're so happy to have you here today, and we're incredibly happy to have a guest presenter with us, Christy Baynes. We'll talk some housekeeping items here in just a moment, and as soon as we've done that, we'll open the floor to Christy, who will be discussing for us ethics in aging care. And as you all know, who are frequent flyers with us, June is a month that we've dedicated to topics covering ethics. As you all know, as nurses and social workers, these are foundational for you to renew your certificates. And so getting a smattering of ethics classes in 1 month and getting that out of the way and then going to the beach seems like a good thing to do. So we are doing ethics all month, beginning with today. We're doing the ethics of aging care. Hey, Katrina, how are you? Katrina, you're always good to post this, but as we're getting going, I want to get into housekeeping and just let everyone know, again, who's been with us and who hasn't been with us, to let you know that in order to receive your certificate, you must do an evaluation. That evaluation is done through a tool that we call, or no, we don't call it, they call it themselves SurveyMonkey, and we use that. And I want to read that to some of you because I know that there are many of us who are participating by phone or some other mechanism and are not able to see the screen. Those of you who can see the chat room, scroll up or down it, or really up it, I guess, and you'll see the evaluation link. For the others, I'm going to read it here in just a moment. It's SurveyMonkey. It's a secure server site. We do ask for your email, your employer, and your number if you're a social worker or a nurse, or if you're another, clinical course like a physical therapist or others. These should be transmittable for you. It depends on your state board. We're credentialed by the State Board of Nursing and the State Board of Social Work to offer certificates. The nurses' certificates we will be posting to the nursing site for you. Social workers will receive, and in addition, nurses will receive a certificate for your use. The evaluation tool, once again, is SurveyMonkey, and that address I'm going to read to you now. It's https://www.surveymonkey.com/all uppercase, T as in Tom, Z as in Zoo, T as in Tom, K, H, M as in Mary, G as in girl. So once again, for those of you who are making a note of it, our evaluation link following the presentation is at SurveyMonkey. That address is https://www.surveymonkey.com/r/all uppercase, T as in Tom, Z as in Zoo, T as in Tom, K, H, M as in Mary, G as in girl. That's our evaluation link for the SurveyMonkey, and it is password protected. So about 45 minutes into this presentation, I will interject and, excuse me, Christy, but interrupt and offer up to y'all the password. I'll also place it in the chat room. It's necessary for you to have to open the survey. So the password, code word, whatever word you call it, it is necessary for you to have it to open the survey. Do listen for it or watch for it as Christy gets going. So we're still having people come in the waiting room, but I feel like it's probably time to begin for all of you who are kind enough to interrupt your day and share it with us. We do appreciate it, and we appreciate all that you do. We're joined by Christy Baynes today. She's a longtime friend of mine since really before I think I started doing this work. And I think so much of Christy, I actually had her do geriatric care management services for my own parents. Now, mind you, I'm in the business of aging care, and yet I turn to someone else. What does that tell you? It tells you she's very competent, right? And I want that to be very present. Christy is a geriatric care manager. This is a certification. It's not like you simply put a shingle on the door. So she's been through a great deal of training and is continuing to train herself, has grown her staff immensely. And I'm so pleased and happy for her success, and so grateful to Christy for joining us and sharing her knowledge at no cost to me and no cost to you. So these are free CEUs. We hope you enjoy them and continue to use them. And at this time, Christy, I'll open the floor.
Sure. Thank you, Sean. I appreciate the invitation and glad to be with everyone today. When Sean shared the reach that he has with this program, which is great. That's wonderful that we've got someone out there that can offer CEs to all these disciplines across the state. You mentioned East Alabama Medical Center. You've got several folks out there. I actually, early in my career, my position as an assisted living administrator started in Auburn at East Alabama Medical Center. So that was in 2001, 2002. So I've been around the block for a little while. I got into geriatric care coming out of college in 1998, and have loved it ever since. So definitely this is my passion, and I know many of you work with seniors. We actually are, so my company is called Life Care for Seniors, and our profession is called Geriatric Care Management. However, over the last several years, the national organization has changed to Aging Life Care. And we are seeing younger and younger people with chronic illnesses, whether it's, an injury like a traumatic brain injury, or it's, a disease that they developed when they were young or at birth. We are looking to, a lot of our clients are younger than I am. I mean, not a lot of them, but several of them could be younger than I am. And so we are actually looking at a whole new branding of life care solutions. And I think that everybody in this industry is seeing that it's not just the 80, 85, 90-year-olds that we're working with. We are working with folks in assisted livings and independent livings and home health that are not just the older population. And it does make for many questions and a lot of collaboration between all the different disciplines that we work together. I laughed with Sean because he gave me a real boring topic, but it is something that we have addressed every day. So I will be referring to, and I'm going to let everybody see this. So I'm going to stop share for a second so that you can see this a little bigger. This is like the old school care management edition. I think there's probably this is 3rd edition. We're probably on about 10, 15 editions now. But that is what I'm going to be referring to a lot. And I'll go back to my ethics in healthcare. This is actually kind of like the Bible, if you will, for those of us that have grown up in geriatric care management. And care managers, we touch really all disciplines, very similar to, Sean, in your role in helping people with placement. So from, working with legal teams, lawyers, trust officers, financial institutions, discharge planners in the hospital, the multiple doctors, home health, hospice, caregiving groups, private caregiving groups, daycare programs, insurance companies, and of course, family members and lots of family members and neighbors and so forth. And from the most part, everybody that we touch and are working and interact with want the best for that patient. So we call them clients, but for most of y'all, particularly if you're in the inpatient field or a clinic, we call them patients. So I'm just going to refer to the patient. We all want the best for these folks. However, particularly in senior care or in dealing with persons that have memory issues or mental health, our program has really grown a lot in the mental health area. We are faced all the time with ethical dilemmas. And I'm going to present a couple of things today, and it doesn't mean that we're going to solve these ethical dilemmas. It's just giving us tools in our toolbox and how to address some of these things. I do not like to be a talking head and reading from things, but again, some of these things just don't roll off my tongue on the ethics stuff. So I will be referring to this. So excuse me for that. But, I do want to talk about a lot of these things. All of us have been faced at times where what we see with a client, particularly somebody with a mental health disease or a neurocognitive disorder, any of the dementias, whether it's the family or it's the person, the patient doing something that's not in their best safety, or could be causing harm, we're faced with a situation where this happens. What do we do? Because we also have to protect their, patient privacy, their wants and needs, their wishes. What does this look like? So we're faced with this a lot. And I'm gonna kind of go through this. And at any time, Sean, I don't necessarily see the chat questions. If somebody has a question, again, I hate to be a talking head. So if somebody wants to raise a hand and say something, Sean, you are not interrupting, interject and say, hey, Sally's got a question. This is y'all's program, not my program. I'm just here presenting.
Well, y'all listen to what she's saying is ask questions, y'all.
Yeah, please do. And I don't talk all the time, right?
Right.
Okay, so what are the objectives for the day? This was in there, in the program that I sent to Sean originally. And again, we're all faced with ethical dilemmas daily, right? We are people serving people. And guess what? People make mistakes. We will make mistakes, and sometimes that can come into play with this, or it can come into play. Maybe the patient's made a mistake or the family, whatever. And so there's going to always be kind of nebulous area, particularly in senior care, if you will. So between content, the patient's safety and their autonomy, issues of when should we disclose a problem, when shouldn't we disclose, is somebody being exploited, maybe there's a new relationship of things going on. We see this all the time. And there are so many scams right now that are just being pushed on our folks that are isolated. The last couple of years have just really ramped up mental health issues, the catalyst for dementia and things like that, because we isolated everybody. Yeah, we had to, right? Because of the virus and things like that. And from our team's perspective, we followed everything and everybody was super safe when it came to COVID. But I remember probably maybe like this time of year, after we had been in lockdown for a couple of months, and then we were kind of starting to do a little bit of things, but we couldn't, there were some communities that understood how important it was that we came in to see our clients. And then there were others that were just completely shut off. And I remember going, what are we doing to our folks? What are we doing to them? And what is it going to look like when they can finally be seen again? And we're seeing those issues now. There are a lot of problems that are going on with people that have just been super isolated. And so we've got folks that there was a gentleman that was in an independent living community. And I guess because of his rights, they couldn't do much as far as getting others to engage to help him. But by the time we got called in a situation, this gentleman had over 1,000 bed bugs in his bed.
Oh my God.
You scratch your head going, how did somebody get like this? And they were in a community, right? So if that person who was actually in a community could get to that point, what are we seeing with people in the home? And, you know, folks like Sean, you get an opportunity with this. Home health and hospice gets an opportunity. Of course, we do. But the folks in the hospital have no idea what's going on at this patient's home and what to return.
Right.
And a lot of folks can kind of shake their head and tell you what you want to hear. But when you go to their homes and you realize there's one serviceable bathroom, they're in a nice community, but there's one serviceable bathroom, and that toilet's about to fall through the floor into the basement. Their son lives out of state, can't come visit. The person hasn't been deemed incompetent, but yet we've got this dilemma of, you know, do we need to report this? How do we help this person? You know, because we work a lot with the county guardians and conservators and folks that are, you know, award whether they're a protected person to their family or a protected person to the state. And you hate to get to that point. You never want to strip somebody's rights away unless it's just to the point where they really need safety. And so we have to look at those things and go, how can we help them in this situation, keep them safe and healthy? We also have that moral obligation that, you know, if we see something, what do we report and when do we report it? So there's just all this navigating, because then again, when you do report things and Adult Protective Services is really backed up, how long, you know, is this person ever going to be seen? So we're faced with these things all the time. And what I will say, and what I think that the key point that I want to get to everybody today is you got to collaborate with one another. All the disciplines have got to speak to one another. You know, if it's home health, the caregiving group, the family, the doctors, everybody needs to communicate with one another to come to a good consensus on how to help these people. Because whether they have a mental health problem or a neurocognitive disorder or some other type of debilitating disease, they need help. And how can we come together to help them? And that's really the biggest collaboration that we see is you got to just put the problem out there and how do we solve it with keeping that person safe and maintaining their dignity and quality of life and their choice, right? Keeping their choices. So again, takeaways, we're going to talk about a couple of ethical dilemmas and discuss what could we do in these situations. I'm going to use my handy dandy handbook, and we're going to talk about how to analyze ethical problems and develop appropriate solutions. A lot of this is just common sense. I don't know how often we use the method, the KISS method, keep it simple, silly. I won't say stupid. But when you boil it down to things, sometimes we make these problems bigger than they should be, and we just need to keep it simple and communicate with one another. And then how do you resolve these ethical dilemmas that we can be faced, right? And I think, again, the big key point is collaborate and communicate. Huge. You know, the three principles of our company are understanding, compassion, and guidance. And then we also want to talk about connectivity, communication, and collaboration. So between those, that's always what's in the forefront of our mind when we're working with our clients or patients. So I think that's the key thing, again, in working through the ethical dilemmas that we're faced. So I'm going to tell you what the pledge of ethics for a geriatric care manager is, okay, but it's going to be the same for everybody in healthcare, right? Again, so whether it's a home health company that's under CMS rules, it's a caregiving agency. Caregiving agencies in the state of Alabama aren't licensed. So, you know, you can have the private caregiver, you can have a smaller kind of collaborative, you know, referral caregiving agency, or you can have a really big caregiving agency like a franchise or something like that. So we all are bound to what are the services are we providing, and are we being open and transparent to our clients and patients of the services we can provide. Just the pledge of ethics that we have to uphold as care managers, that it starts with, I will provide ongoing service to you only after I have assessed your needs and you or a person designated to act for you understand and agree to a plan of service, the results that may be expected from it, and the cost of service. So in a care manager's role, the first thing we do is go in and do our full psychosocial clinical assessment. That can involve, ADL screen. We use the slums versus the mini-mental, depression screen, observation of the home safety, their nutrition. We're looking in refrigerators, how they do their medications, even from the legal standpoint, financial, we look at all of these things in an assessment. So if I'm looking at home health, hospice, the discharge planners in the hospital, they're doing assessments there. And so when I look at it from the whole perspective, are we assessing that patient? And then are we coming up with the plan for them? So if I look at, like, say, a discharge planner in the hospital, has that discharge planner collaborated with all disciplines, with the hospitalist team, with the patient, with the family, if they have family, with therapy that's come in? Before we decide on this discharge plan, has this patient or the patient's proxy had ability to look at everything and help make the right decisions on the plan going home? We get surprised sometimes when people are discharged and you're like, wait, what? Hold on a second. Why wasn't this addressed, that addressed? And it's not necessarily that it stopped with the discharge planner, but did that discharge planner, was she or he able to get all the things within the hospital? Were they able to collect all that information to then give that to the patient, and then be able for the patient or the patient's proxy to make the decisions moving forward? Self-determination. I will base this plan. So again, as a care manager, I will base this plan on their goals. It's not my goals. And I think sometimes we as healthcare professionals, because we do have the knowledge and the experience, it's easy for us to kind of project what we think, right? But ultimately it needs to be that patient's choice within boundaries, right? Our goal or our responsibility is to give the information, present the information based on our assessment, and then help them decide. But again, they've got to decide those things. We can't force those things on it. And that goes along with cooperation. Are we getting together with the family, with the patient, and helping them make the best decision moving forward? There are plenty of times in my 24 years of doing this that I have made decisions quickly and hastily because, maybe I needed to get something done quickly or something like that. And I didn't take the time to put everybody together and make sure that the person that we're presenting the information or presenting the choices for felt like they were collaborating, right? So it's very easy for us in the service industry to get in a pressure situation and just kind of put something out there. And that's where we need to pause, stop, make sure our patients and their family members, if the patient wants the family member, right, involved, make sure that they have collaboration and feel like they are connected. Referrals and disclosure. And Sean, you can speak on this too. I mean, we kind of come from a different perspective because our clients pay us for our referral, for our recommendations. You're in a different, you have to disclose your relationship with the people that you refer.
Right.
A discharge planner in the hospital, they're bound to give the whole list, right? It
Right.
can be a list of 15 facilities and 15 home health agencies and things like that. So however your particular discipline, whatever your guidelines are for referrals and disclosure, you've got to disclose that to the person that you're working with so that they have that knowledge, right? Do we get into the habit of referring to some of the same people? Yeah. And why? Because a lot of it's because we have relationships with them. Before Sean and I jumped on with everybody today, we were just kind of talking about, the landscape and how it's changed over the past couple of years. And for us, and I know for Sean too, who we refer can really depend on this. Well, for us, and I know for Sean too, it depends on the service at the time.
Right.
It's the right service for our people, right? So a community that I might have referred to 5 years ago, maybe they've changed leadership and maybe they've changed their model. Maybe they've changed names. I mean, how many times do we say the artist formerly known as, right? I mean, small companies get bought by big companies and whatnot. And so in that situation, who I referred 2 weeks ago might have changed in the last couple of weeks. And so I need to disclose why I'm referring to our clients. For those of us that, if you're home health and hospice, so I'll use those two, for example, your termination of service is going to depend on their recertification, right? So did somebody recert for more home health services? Did they continue to meet the qualifications for hospice? I do think that's really important to have that constant communication with the patient or the patient's proxy so that they understand, particularly our folks with dementia, if they're getting to a point where they're plateauing, like they continue to refuse service or they can't follow, or they're in rehab, short-term rehab, and they're continuing to refuse service. And then the family's like, well, why didn't therapy work with them? Or why didn't you do this? If family could have a better understanding of, okay, CMS sets these guidelines for us, and your particular insurance company, whether you're under a PPO, an Advantage plan, or whatever, if you give them that communication in the beginning and you tell them these things along the way, so they're not just shocked at the end, and sometimes they will be shocked, even though you've given them all the communication you can, but at least you can sleep at night knowing you have. But you've got to give them the communication along the way. I don't know how many folks we have here that are in SNFs. I will say this, for those that are involved in short-term rehab, please meet with the families and the patient, make sure they understand where we are, and you're supposed to, and I think everybody does, but I do think coming out of COVID and how we were restricted and people weren't able to really be there in person, I think some of those kind of habits that we formed over the last couple of years are still there. We can make our lives so much easier as healthcare providers by communicating. That's it. Just tell them, okay, your mom has been refusing therapy the last few days. You only have so much, we can only, if she refuses therapy X amount of days, we're going to have to discontinue the service, right? So, for our perspective as care managers, in our long services agreement, it tells the payer and the financial responsible person or the client when they can terminate service. What does it mean to terminate service? So that's from my perspective. But for most of y'all on the chat today, you probably are coming from a hospital, skilled nursing rehab, assisted living, home health, hospice, those kinds of things. And for many of you, you're under an insurance or you're under, a particular set of rules and guidelines. Just communicate. That's the key. That tends to be where the problems arise when you can't communicate. A lot of families would get frustrated during COVID, and I did a whole series actually, with a big financial firm here called Oakworth Capital. And they were presenting this to families and their employees and so forth. And they brought different senior experts in to talk about how to handle navigating senior care with your loved one while they were in isolation and visitation was restricted. And one of the word that stood out to me the most, that I really wanted to give those of us that are working in healthcare, and of course the ones that are receiving our healthcare, is grace. Just give grace. We're all stretched. We were all stressed. We are in a high stress industry, and so we do have to give grace to one another. But on the flip side, we also got to make sure that we're communicating with one another. Confidentiality. Obviously, we're all under HIPAA rules. We know HIPAA. How many times have we had to sign HIPAA and privacy rules and rights and things anytime we go to the doctor? We're sharing these things. It's in everything that we do, right? Whether it's the hospital, the assisted living, we share it, we do it all the time, but we kind of take it for granted. It floored me the other day. I have a family that we work with, and one of the spouse is a former physician, and that spouse had referred another family to us. And when I was talking to the spouse that was a former physician, that spouse was asking me about the family that he referred and wanting to know information about this particular person. I was like, I can't disclose anything to you, but we build these relationships with these families that they feel so connected with us. And it looks like it's chit chat, like we're just, friends talking to one another. But again, just upholding those things are really important. But there are ethical dilemmas when we're faced with, whether it's a situation between family members that we see an abusive situation from one family member to another, and then the client's telling you not to share, or it's, someone that scores poor on a competency exam. There's all different kinds of things that we can get faced with.
Well, and that in itself was, a massive ethical issue, having a referral source ask you about another referred party, and you want to maintain that relationship clearly, but that's a sort of 2-second like crisis moment when what do you do?
I just said, I appreciate your concern for that person, but as a doctor, I can't do that. Oh yeah, I understand. And I kind of laughed it off, because I didn't want to totally offend the person, but I just kind of kept it like that. Because no, it is. We do get so connected with these folks.
Yeah, and you don't realize it. I think in the course of a day, you would not have entered your day thinking, I'm about to face a very serious potential for an ethical breach today.
Right.
And you don't think about it at the moment. It's just like you said, it's just chit chat. But it is it's a very serious moment.
Yeah. Oh yeah. I can't tell you, my precious in-laws live in the community where I'm in, and we go to the same church, and they're in a big Sunday school class, and they'll say, oh, Christy, we heard so-and-so and so-and-so, the Smiths or the Browns told me about you. And I'm like,
right.
And they know as soon as I start nodding, they're like, you can't say anything, can you? I'm like, no, sir.
Right.
If they want to tell you, that's fine.
Right.
Anything. It gets in a precarious situation.
Yeah.
So substitute judgment, what does that mean? That would mean you were acting as someone's proxy, right? A proxy or a power of attorney or something like that. And the only time you can ever do that is if you are legally assigned to be that person's representative, or so forth. And that, I don't know how much that's going to come into play for folks that are in the hospital or skilled nursing or home health and hospice. For those of us as care managers that, that we're ongoing with our families, we can get in a situation where the hospital looks to us and says, okay, this person needs surgery. Can you consent? I can't consent, right? I can share the information with the person that can, but ultimately it's got to be that person, the power of attorney's decision or whatever. And if that person doesn't have the legal representation, then it falls to the situation where it may have to go to the state. I mean, although we would make the right decision, we still legally can't make that decision.
Right.
Loyalty to the client, to the patient, those kinds of things. Are we maintaining our qualifications? Wow, I'm preaching to the choir today. 134 participants. Go, Sean.
Yeah.
Awesome. So I'm preaching to the choir, all the people that are continuing their education and so forth. Are you maintaining those things? And then obviously, we cannot discriminate in any situation.
Hey, Christy, we have a question. Holly Skelly asked, what if the client does not have legal representation? Who does it fall on? And she didn't hear us discuss that yet.
Yeah. That's a great question. If the person is competent, then it's gonna fall that then they can make those decisions. If they are not, it really is going to depend on the setting that they're in. So obviously, if they're in the hospital, then it's up to the hospital to go through that situation. And that's where sometimes the hospital has to refer to, petition for an emergency petition for guardianship and conservatorship. And that's going to be county to county. So obviously in Jefferson County, we do have county guardian and conservators. Each county is going to be a little different. But that's Sean, you could have a whole month on substitute judgment. And it gets a little hairy. And so what I would say in that situation is refer back to, obviously, if it's home health, hospice, those kinds of things, go up your chain of command to, your legal team, your quality assurance team, your ethical team, anybody that's involved so that you can then make, you can make the right recommendations or so forth. You can't make the decisions for these folks because you're not legally bound for them. But that's a great question. And it's one of those that it's not a black and white. It is a black and white answer, right? Either you can make a decision for somebody or you can't. And really the only way you can make a decision for somebody is if you legally have that responsibility. That's it.
Sandra Howard says each state has a hierarchy of who would be legally allowed to make medical decisions.
Right. You got it.
Thank you, Sandra.
Goes to state, goes to county, and again, I think probably most people here are working within a company. I would go up to whoever is in charge of legal, ethical, quality for your company and ask those questions. The key is, and I think what happens, because those of us in the service industry, and particularly in geriatric care, we want to we're in the moment, right? We're in the moment and we need to we want to make sure that this person has the right kind of care, is being cared for, is protected, is safe. Like the keys. We know somebody shouldn't be driving, right? There are even doctors that don't want to write that somebody shouldn't be driving.
Right.
Because there's all this liability and things like that. We can say, we don't feel like it's safe for you to drive, but none of us legally can take somebody's driving rights away. we can report things, we can recommend the driving assessments, those kinds of things. We can present options. We cannot make those decisions for them. And so again, great point to all of your participants. If it's from a company perspective, if you're faced in a situation in the home with someone, don't be afraid to say, that is something I can't answer right now. I'll get back with you. Take it back to your company, take it back to the people that can help you with that decision. And then ultimately it is going to fall back on, county, state, what they have within those barriers for those kinds of decisions. Let's see. So we've talked about all those. Great questions. Thanks. Keep them up. Oh my gosh, we're already at 12:40. We've talked about this, and this is kind of a boring slide, so we're going to keep moving. Examples of ethical dilemmas. So we're going to go over a couple of these. I didn't even realize how long we've been talking. And then I want to get to kind of the key page, which is collaborating and things like that. But we've talked about these. Conflicts between when a client wants and needs something and what should be done, right? Driving, living at home in squalor, they're not taking their medications correct. I mean, there's all different kinds of things that come up. Again, client exploitation. What about these folks that have been socially isolated? They've had no one. Now they finally have a relationship with someone, and this person is showing love and compassion to them. But then you're kind of scratching your head because you're looking at it and going, yeah. But all of a sudden, this person keeps bringing in new handbags and things like that. That has, this relationship is kind of going in a weird situation. What does that look like? Again, client safety versus client's autonomy, and when to disclose and when not to disclose. So here are the key things. Analyzing ethical problems, and we can break this down even more. And I'm happy to send some of this to you, Sean, that you can share with everybody.
Yeah.
Give me a day or two and I will break some of this down even more, and I'll send it to you and you can send out to everybody.
That'd be great.
A great exhibit in this handbook that breaks down all these things. So obviously, one, review the situation, right? What is the current problem that we're facing? What health problems exist? First off, asking those questions. What decisions need to be made? And what components are ethical and which are based on scientific knowledge? Okay, so break that down. What are things that are like based on like medications? They need to take their medications. That's scientific knowledge. They need to take their medications. A relationship, to drive, not to drive, to live in home, to, people will say, well, I want to stay at home, but then they can't afford the care at home and their home's not safe. And so you've got to look into all those different things. Are we gathering all the information necessary to make a decision, right? So analyzing and putting everything out there. What are the relevant ethical principles? So what are the historical, philosophical, and religious bases for each of these principles? We're going to work with folks that have particular religious beliefs that we need to respect and uphold for them, right? And that's information that we've got to get when we go back to that assessment to make sure that we know our patient and our client so that we can help them with these things. What are their values and beliefs, right? What we may do at our own home doesn't mean that they can do that they may want to do that in their home, just as long as what they're doing is safe and responsible. What are the values and beliefs of others in the situation when you're dealing with family members? What are the conflicts in the situation, right? And a lot of times there can be conflicts between providers, conflicts between two adult children. Put it all out there. Who is the best person to make the decision? Sometimes we come across a person that doesn't have a power of attorney and has 3 adult children, and who's supposed to make the decision, right? And maybe the loudest person is the person that may not have their best interest at heart. What is the fullest range of possible decisions and actions? Again, I think the key to all these things is not to make knee-jerk responses and reactions. If you're faced with a situation that you're scratching your head and going, you know what, this just is, something's not right here, engage, involve other people, and make sure you've got all the information. Decide on the course of action and take steps to implement it, right? So again, collaborating with everybody, and then continue to evaluate those outcomes. Oops, sorry for a little typo there. But I think the key is, Sean, with everything is to negotiate, compromise, look at the whole situation. When does a decision just need to be over? Like, when does somebody need to override it? And that could come back to legally, you can only do so much. And so that's going to override your decision, right? So if somebody is living in complete squalor, not taking care of themselves, but, doesn't want to be alerted. But for us, we need to report that to Adult Protective Services, DHR, those kinds of things. Just like in the hospital and, in the communities, if a home health nurse sees that a situation is going on in the home, they're legally bound to report that to their company, maybe even DHR. So again, that's appealing to a higher authority. Involve the whole care team and definitely seek collaboration. Okay, I thought I was gonna, not talk for long, that this was gonna be I might talk about ethics for 15 minutes, but I'm a talker and I talked for 46 minutes. So
You can see it's not boring at all. Not boring at all. It's a good topic.
I don't know. I'm going to leave it at that, but I will definitely get this information to you, Sean, that we can break down.
We have folks asking. They do want to see that from you, Christy. And then I want to give the password code word to our survey is actually the name of your company, Life Care. Okay. LIFECARE, one word, Life Care. I've put it in the chat room for y'all who are able to see the chat room. Invariably, people reach me and say, I can't open the evaluation. Remember that it's password protected, and the password is one word, Life Care with a capital L. And Christy, we thank you. I'll tell you on the side, I know she didn't count on this and she has a hard stop here in a minute, but Christy did, I think I said earlier, Christy did work for me years ago. My stepdad had cancer and had complications, had C. diff, had an ostomy. And I had asked Christy, I guess prior to the ostomy, had asked Christy to come and do an evaluation because my goal, given what I do, I felt my mother was both hurting herself and hurting him by being his sole caregiver. And I wanted him to go into a community, but I needed another person, to say what I'd been saying all along, which is a lesson to everyone. You are perpetually 12 years old to your parents. I don't care what you do. They're not going to listen. You need a third party, which is why I exist, and Christy. And so I brought Christy in, and my stepdad was napping, not feeling well that day. So she ended up sitting in the kitchen and talking with my mother. And as we drove home, and she was kind to ride with me, it's a 2.5 hour drive. We drove home and she was saying, well, I didn't get to spend much time with your dad, but your mom concerns me. I think your mother is early stage dementia. Well, here's the ethical issue. I didn't believe it, right? And what does she do? Substitute judgment was the topic she presented us. So the adult child who does this for a living, was not taking her advice about my own mother's incompetence. And I don't mean incompetence in any other way other than her mental cognitive dysfunction. And so I didn't listen to Christy. And Christy, I haven't told you this, but 3 years ago, my mother gave away everything she had to someone who loved her, who called her from the sweepstakes, Publishers Clearinghouse. So not only was it a sweepstakes scam, it was a love scam, a sweetheart scam. Sweepstakes and sweetheart, they were going to run away together and spend the $3 million. And it wasn't until I was caught, and this was another ethical thing, a banker called me and said, they said the code word's not, well, I'll fix it, ladies, don't worry. Remember, it's not 2 words, it's 1 word, Life Care with a capital L. So I ended up, the banker called and said, I'm not supposed to do this ethically or legally, but your mother came in to open a $70,000 loan with you as a co-signer, so I thought I could. And so that day I went through and found out that day that my mother, I'll fix the thing, Katrina, it'll be just a second. Thank you though for pointing that out. So, you know, he broke an ethical promise, but he did it for the right reason, right? To save her. And, you know, it was just a complete horrible thing, but it's one that just taught me a lot. And so I always thank God for opportunities and challenges. And even though this was not a good thing, oh, here's someone saying it worked for her, but it had to do it twice. So y'all keep trying life care, one word, capital L. So anyway, I just point that out because one, I wanted you to know it, Christy, and two, I mean, there are a lot of ethical issues within that context, and I failed, failed on most every charge, but you know, that's the complexity of this. It's not a simple topic. It's not an easy topic. It's nuanced. And this is where we have experts like Christy come in. And Christy, I know you've got to go. Thank you so much.
Thank you.
And y'all, I'll keep talking. Thank you, Christy. I'll keep talking if you like, and we'll lowercase c instead of capital C, y'all, on the presentation. So if anyone has questions for me, please put them in the chat room. If not, guess what, y'all? It's 50 minutes, so we've satisfied our CEU. And I believe I can let you all go and maybe go get a snack from the vending machine before you go back to your busy day. I thank you for being here. I invite you to be here on Thursday when we're going to discuss ethics during COVID-19, which is still present, y'all. COVID-19 is not over, so we're still in the ethical dilemmas presented by COVID-19. And we'll go into that on Thursday. Later this month, we'll do the ethics of treating the blind. I've had one of y'all, and you'll see as you do the evaluation, I ask you for suggestions, and one of our folks has been very good to many times suggest that we do topics relating to the blind. And I thought, what better topic relating to blindness than the ethics of being blind and being treated as a blind person? So we look forward to that later this month. And we also have at the end of the month on the 28th, especially you social workers, but everyone, we have self-care for the social worker, which is now required to renew. So y'all make sure to put June 28th down. It's a Tuesday. We'll have a guy Chandler Caldwell, who's recently completed his PhD and taken a position in West Alabama with those who are underserved and underprivileged. So pleased for him, and so happy that all of you were here, and look forward to seeing you later this month. I'm assuming that Life Care is working for everybody now on the survey. I haven't seen any information from you that it's not. Thank you for your kind comments. Thank you for being here, and thank you for all you do. Y'all have a great rest of your day, a great week, and hopefully we'll see you on Thursday.